So now I will show you some case reports where we have shown how we can monitor these cells over time. And the first action often is neoadjuvant chemotherapy. That means chemotherapy when the tumor is still present, and you can then see whether the tumor shrinks upon chemotherapy. And this is an indication that the chemotherapy is effective. But it's also important to know that when there is tumor remaining, which then is removed by surgery, this can be highly relevant event during the course of disease. And I'll show here now. This is a patient where we also did chemosensitivity testing. And as you can see, docetaxel and doxorubicin were the most effective ones. And they were also used for the patient. It was a 48-year-old woman diagnosed with breast cancer with T2 tumor and lymph node involvement, but she was estrogen and progesterone positive and HER2 negative. She got this treatment with doxorubicin and cyclophosphamide and docetaxel, and she had a very good clinical response, so her tumor disappeared. She then had surgery, and surgery revealed a pathological complete response, so no tumor detectable anymore under surgery. She then received radiation and subsequently tamoxifen. As you can see, she decreased in her cell numbers, but surgery was able to mobilize cells again, and these cells remained stable under radiotherapy and stable during the whole treatment with tamoxifen until now. So these cells were released, but they were not active, and she is currently without disease. Another patient had an increase in cell numbers during the AC treatment. So it was a 49-year-old patient diagnosed with breast carcinoma, again, T2 and 1, no metastasis. Estrogen receptor positive and HER2 low. That's the new categorization. And she had a high fraction of dividing cells. She received neoadjuvant chemotherapy, but she increased during this therapy. She then had surgery, which led to a decrease in cell numbers, but she is at risk because she did not really respond to the chemotherapy. So then we can test also the circulating tumor cells before and after surgery. I already showed before that the one patient increased her cell numbers during or after surgery, and the same occurred here in this patient. This patient subsequently had radiotherapy. She had a smaller tumor, and no lymph node involvement. She also was HER2 low and estrogen receptor positive and progesterone receptor positive. She has not received any more therapy than radiotherapy. I would like to emphasize something which I will later point to, that patients who have had neoadjuvant treatment and increase in their cell numbers during radiotherapy are at especially high risk. Now I will show some examples of adjuvant chemotherapy. So this again was a patient where we tested the epirubicin and the taxanes, and she received epirubicin and paclitaxel adjuvantly. She was a 38-year-old woman diagnosed with breast cancer with a small but lymph node positive and HER2 negative. And after surgery, she received the adjuvant chemotherapy, and we could show that previously her treatment options were good with the two drugs, and this led indeed already to a reduction of circulating tumor cells to a very low level, and this was further reduced during tamoxifen treatment, and currently she is relapse-free and well. Now I will talk about radiotherapy, which is used in almost all patients if they have breast conserving therapy or involved lymph nodes. This was a patient who was 40 years old. She had clinical T1C and lymph nodes involved. She was estrogen receptor negative, progesterone receptor negative, but HER2 positive. She also received neoadjuvant chemotherapy with estrogen and epirubicin cyclophosphamide and docetaxel and Herceptin, and then had surgery and radiotherapy. And as you can see, after surgery, in spite of Herceptin treatment, she had an increase in cell numbers, but later she decreased. And as I mentioned before, we have shown in a study that patients who had an increase in cell numbers during radiotherapy, although we do not know whether it's due to radiotherapy, it may be the characteristics of the cells, but if they increase in numbers during the time of radiotherapy, they have a very poor prognosis with 50% relapses occurring also already in very early time, whereas those with decreasing or stable cell numbers during the time of radiotherapy have a good prognosis. And the difference is highly significant, and we have published this recently in about the radiotherapy treatment. This is especially important more for neoadjuvantly treated patients than with adjuvantly treatment. So the neoadjuvantly treated patients have a higher risk if they have increasing cell numbers. We also can monitor the cell numbers during maintenance therapy, which mainly is hormonal therapy or in breast cancer patients. And as you can see here, this is a case of a patient who had small breast cancer, but G3 and a relatively high division number, Ki6, 67, 25 to 30%. She was estrogen receptor positive, progesterone receptor positive, and HER2 negative. She had neoadjuvant chemotherapy. She reached a PCR and had surgery in 21. We only monitored her after the radiotherapy and during the maintenance therapy with tamoxifen. And here you can see that even with a small variation, cell numbers remain relatively stable. And in the end here, under complementary therapy even decrease, and she has a good prognosis. In contrast, here is the case of a 60-year-old patient diagnosed also with a relatively small tumor, estrogen receptor positive, progesterone receptor positive, and HER2 negative. She had surgery in 22 and had maintenance therapy first with letrozole, under which her cell numbers increased. Then she had a 1-year break, and indeed her cell numbers did not increase further. And now she's on the anastrozole but she is a patient at risk, which should be tightly monitored. Another patient, 45-year-old patient with tumor size not known, no lymph node involvement, no metastasis, estrogen receptor positive and progesterone receptor positive, HER2 negative. She had surgery in 21 and then radiotherapy, which we did not monitor, but we did monitor the maintenance therapy with tamoxifen, where she remained stable. But now with letrozole, she is increasing in cell numbers. So should be considered whether letrozole should be given continuously. We do not know whether she has her ovaries still present, but maybe letrozole is not sufficient to inhibit estrogen production in this young patient, and maybe tamoxifen would be more helpful in this patient. Last not least, I would like to show how immunotherapy can be monitored. This was a patient who had first a decrease in cell numbers, but then her cell numbers increased and she had treatment with carboplatin and paclitaxel and pembrolizumab. And as you can see here, the triple treatment led in the end to a decrease in cell numbers. So we cannot test like immune therapy like pembrolizumab directly on the cells because it interferes not with the cells themselves, it interferes with the interaction of immune cells with tumor cells. And this we cannot test in vitro, but we can look for PD-L1 expression, which is involved in these reactions, and we can then help to see whether these cells have a chance of responding to the immune therapy or not. And I'll show one longer course of disease here, where we looked for the neoadjuvant chemotherapy in a 55-year-old patient who was estrogen receptor positive, HER2 positive in Ki67-20%. She received the common treatment, which we have with EC or AC. She had EC and 12 times paclitaxel, and together with trastuzumab and pertuzumab, because she was HER2 positive. She then had surgery and radiotherapy, and her cell numbers decreased nicely. She had then maintenance therapy with hormone therapy, but she discontinued the anastrozole and started with exemestane, which she only had for a relatively short time. But we can see that her cell numbers remain stable and even decrease now over time. So this patient looks like being a good prognostic situation. Okay, I'll show the next here. The recommendations for timing of blood sample. This would be before neoadjuvant chemotherapy to see what the basis is and possibly testing the drugs in question. Then if you had the neoadjuvant chemotherapy, you would test after the end of neoadjuvant chemotherapy about 3 weeks before, and then 3 weeks after surgery to see whether cells have been mobilized during surgery. Then if you have adjuvant or neoadjuvant chemotherapy, you could test 2 to 3 weeks after chemotherapy cycles. We would recommend to test after every third chemotherapy cycle. Then testing may be meaningful after completion of a chemotherapy, and then every 3 months during hormone or maintenance therapy, and blood sampling is possible here at any time. And also we recommend to test later during the therapy-free period to see whether cells can be activated again. And so we think that the maintrac testing enables determination of the number of ETCs at any time point during therapy in breast cancer. The therapeutic substances can be tested to help to select the most effective ones. The tumor characteristics can be tested to select the targeted therapies, for example, estrogen receptor or Herceptin or the new Herceptin-dependent drugs. And StemTrack can help you to estimate the recurrence risk. So this is the end. And please, if you have questions again, and you can also contact us at maintrac@laborpachmann.de. Thank you all who have been attending, and thank you for your attention.